Next, we'll hear from Dr. Nadia Ghazali, who will speak to us on an analysis of outcomes in resected early-stage non-small cell lung cancer with rare targetable driver alterations.
Thank you. So I'll be presenting this study, and this study was supervised by the legendary Dr. Francis Shepard. So just a quick introduction. There remains to be high recurrence rate after surgery for early-stage non-small cell lung cancer. And this can range between 45% in stage 1B and up to 75% in stage 3, even with adjuvant chemotherapy. And this highlights the need for better, well, I would say neoadjuvant, adjuvant, or perioperative strategies to improve outcomes. And targeted therapies are now standard of care in resected non-small cell lung cancer with common EGFR mutations and most recently ALK fusions. And I think there's still very much limited data on the outcomes in patients with rare actionable alterations after curative intent resection. The objectives of our study was to assess the relapse-free survival and overall survival in patients with resected early-stage non-small cell lung cancer that harbor rare targetable driver mutations. We conducted a retrospective single-center analysis in our center. We included patients with stage 1 to 3 non-small cell lung cancer with rare targetable mutations who underwent curative surgery. We collected data from the tissue-based molecular profiling to identify mutations in KRAS G12C, EGFR exon 20, ERB2, fusions including ALK, ROS1, and RET, BRAF V600E, and MET exon 14 skipping. And the KRAS G12C cohort was used as the reference for survival comparisons. And RFS is defined by the time of surgical resection to the first documented relapse or death from any cause, and overall survival is defined from the time of surgical resection to death. Kaplan-Meier curves were used to estimate RFS and OS probabilities, and we also looked into associations between baseline clinical characteristics, mutation subtype, TP53 co-mutations, and survival using Cox regression. And for the results, we included 225 patients. Majority of them had stage 1 diagnosis, up to 63%. And if you look at the molecular profiling based on tissue, KRAS G12C was the most common mutation detected, up to 45%. And we have quite a bit of high levels of other mutations like MET exon 14, about 12%, EGFR exon 20 of 11%, and even ERB had 11%. The demographics are as shown. The median age is 66.5 years. Majority of them were female, and majority had a smoking history. Adenocarcinoma was the most common histology. Lobectomy was the most common type of surgery, and about 32% had chemotherapy. For 5-year relapse-free survival probabilities, so stage 1, 59% was relapse-free at 5 years, and stage 2 and 3, 53% was still relapse-free at 5 years. And looking at the 5-year overall survival probabilities, our sample actually did quite well. Stage 1, 76% remain alive at 5 years, stage 2, 60%, and stage 3, 58%. And now we want to look at the RFS by mutation type. And again, this is compared to the KRAS G12C cohort. Nearly all of the mutations had a shorter relapse-free survival compared to KRAS G12C. ROS1 actually had probably the shortest relapse-free survival with a hazard ratio of 2.7. And the fusions also, together we pooled, showed that they had a shorter relapse-free survival compared to KRAS G12C. Looking at the overall survival, despite all of the mutations nearly had a shorter relapse-free survival, but they actually did better in terms of overall survival compared to the KRAS G12C. And we could see these fusions of RET and ALK actually didn't have any events at all with our cohort. And initially in the ROS1, they had the shortest RFS compared to KRAS G12C, but here we can see that 88% of them remain alive at 5 years. And then the fusion had actually just a hazard ratio of 0.1. And looking at this Kaplan-Meier curve, just to simplify what I was saying, is that all of the mutations actually had a shorter relapse-free survival compared to KRAS G12C. But if you look at the overall survival, the fusions did better than the KRAS G12C. We also looked at brain metastases, and ERB2 mutation had a higher rate of incidence of brain metastases at 5 years, 22%. We also looked at TP53 co-mutation. 33% of our cohort had a positive TP53 mutation detected on tissue NGS, and this was correlated to a significantly worse overall survival. Conclusion. So most of the rare mutations here showed a poorer RFS compared to KRAS G12C, though the overall survival was generally better. So this dichotomy in the results suggests a potential role of post-operative targeted therapy in this population. This emphasizes the need of prospective studies and clinical trials to actually optimize, well, I would say now, neoadjuvant, adjuvant, or perioperative strategies in patients with early-stage non-small cell lung cancer harboring actionable alterations. And this also highlights the importance of doing comprehensive molecular profiling in early-stage non-small cell lung cancer to guide treatment decisions. Thank you.
Excellent presentation. Did you have access to the treatment information and the patients that relapsed and then probably experienced better OS because they were treated for their alteration?
Yeah, so that was what we think, but we didn't collect that in our study.
I mean,
it's on.
yeah, just to follow up, great presentation, by the way, really nice work. But as a follow-up to Dr. Al-Krif's question, is kind of further demonstrates that stage is a completely irrelevant concept, right? If you have discrepancies in RFS with OS, it's indicative that access to a highly effective treatment upon relapse is what's dictating the survival, much more than whether it was a stage 1, 2, or 3 at baseline. And unfortunately, I think this is maybe a message to Dr. Datchers and all the staging committee people, is that we're going to run into a massive problem with assessing stage if we don't incorporate these therapeutic regimens and the response to them as a component of that, because someone with clinical stage 2 who goes to surgery and nothing else might have a very different outcome from someone who has clinical stage 2 who gets the appropriate systemic therapy up front. So we will have to be mindful of how we integrate all those pieces of information.
Yes, thank you for the comment.
Great job.
Thank you.